So thank you. So now it's time for our first speaker. And our first speaker is Professor Suzanne Epcon, who will speak about a subject which is, let's say, some people feel a little bit neglected. There are girls with Duchenne as well. We always speak about the boy and the man. And they're carriers. There are manifest carriers. So she will speak about girls and women who are carriers and what do I need to know to stay healthy. Thank you so much, Dr. Epcon, for doing this. This is really highly appreciated, and I'm sure in the audience a lot of people will really be happy we start with the women today.
Well, thank you, Elizabeth. Before I get going, can you just let me know if you can see me and see the slide show?
We have both vision of you and the slide, so it's perfect. Thank you.
Excellent. Well, thank you all for this invitation, especially to you, Elizabeth, and to you, Suzanne, for inviting me. I look forward to a time where maybe we can gather all in person. And for those joining today, I hope that this past year and a half has been one with good health, some patience, which I know I have needed, and some grace. As Elizabeth said, I'm going to be talking about girls and women today, which may be a funny way to start off a conference on Duchenne, where, as we know, most of the patients with Duchenne are boys or men. But this is an important topic that, I think that we wanted to make sure that people were aware of, and so decided to start today off with this very topic. So about 2 years ago, I had the opportunity to participate in a conference sponsored by Parent Project Muscular Dystrophy in the United States. The topic of the conference was focused on developing care guidelines for girls and women who carry the mutation on the dystrophin gene. We commonly refer to these women as manifesting carriers if they have symptoms that someone could associate with muscular dystrophy.
Excuse me, Professor Epcon, I'm sorry to interrupt. I think you got your webcam a little bit too low, and it would be great if we can see you fully.
How's that? Is that better?
Thank you.
Wonderful. Thank you for letting me know. The conference brought together women who carry the mutation on the dystrophin gene and have symptoms as a result. There were parents with girls who have symptoms, clinicians, including neurologists, cardiologists, genetic counselors, psychologists, and myself as a rehabilitation physician. The group also included basic science researchers. This two-day conference culminated in a paper that was published last year summarizing our recommendations. And I've included this reference on this next slide for your review. During the next 20 minutes or so, you'll hear me use two terms interchangeably. The more common term, manifesting carrier, refers to a woman who carries the mutation for the dystrophin gene and has symptoms such as muscle weakness and or cardiomyopathy, both associated with having Duchenne-Becker muscular dystrophy. Some of us at the conference advocated for another term to be used, one that isn't very common, which is a female with a dystrophinopathy, or we shortened it by saying FD. And this term specifically calls out the fact that the girl or woman has not only the mutation on the dystrophin gene, but has actual symptoms. I don't think it really matters so much for the purposes of this presentation which term is used, and you'll hear me use them interchangeably this evening. The definition of an asymptomatic person is not entirely universal, but many say it's a girl or a woman who may have mild muscle achiness or cramps, but no muscle weakness. The asymptomatic woman will not have any heart involvement, but a woman who is asymptomatic may have high creatinine kinase or CK levels. There are several published studies that describe the prevalence of symptomatic females, ranging from about 1.7% of women to 22% of those who carry a mutation on the dystrophin gene. This means, however, that most girls or women who carry the gene do not have symptoms. Unlike Duchenne in boys, in which there's a very predictable course of the disease, females with dystrophinopathy vary significantly. There are some that have onset symptoms at really young ages, as young as a year or two of age, and others who present much older. And again, some women, remember, that will never have symptoms at all throughout their lifetime. In one study in the United States, the researchers evaluated 15 women who were considered symptomatic out of a large database. Muscle weakness was the most common presenting symptom and was described in about 80% of those patients. Muscle aches and cramps was the next most common complaint and seen in about 60% of the women. Only one of the patients, so one of the 15 of the women, had very severe course, similar to a boy with Duchenne, with the other 14 having a more mild presentation, like a boy with Becker muscular dystrophy. It is important to note, however, that some of the patients who had a more mild course still relied on a wheelchair before the age of 30. So we would say that's more of a severe Becker phenotype. The pattern of weakness was asymmetric, meaning the right side was different than the left side of the body. And that is not something that we see routinely in boys with Duchenne. But similar to boys with Duchenne or Becker, the women had more proximal weakness, meaning closer to the shoulders or hips, versus distal or out towards the hand and feet. Finally, about a third of the patients had a dilated cardiomyopathy or heart involvement. Similar findings were reported in a group of girls and women evaluated at the University of São Paulo in Brazil. Additionally, they recorded calf enlargement in a group of their patients. This group also taught us that females who were asymptomatic did not, the women who were part of this cohort that did have symptoms also performed some of the time function testing more slowly, such as walking 10 meters or climbing 4 stairs or getting up off the ground. And that the weakness did progress over time, meaning that younger children had less weakness than older women. Now in this slide, I'm going to try to explain the reason why only some females who are carriers of the dystrophin gene have symptoms and not all women. As a reminder, the gene for dystrophin is on the X chromosome. Because boys only have one X chromosome given by their mother, if there's a mutation on this X chromosome, they're going to have symptoms of Duchenne. They will have Duchenne or they'll have Becker muscular dystrophy. Females have 2 X chromosomes, one inherited by their mother and the other by their father. Because there are thousands of genes that are coded on the X chromosome, it wouldn't be a great idea to have twice as much activity on the X chromosome. So there's a random process called X inactivation that occurs, so females don't have twice as many X chromosome gene products as males. X inactivation means that one of the X chromosomes is turned off in a very random pattern, which with 1/2 of those turned off on the mother's X and 1/2 approximately on the father's X. This occurs during fetal development. In the setting of a female carrier of Duchenne, if their healthy X chromosome is turned off in the muscle cells, then this leaves the chromosome with mutation on the dystrophin gene, so that the female may have symptoms. This is referred to skewed inactivation. The term skewed inactivation refers to when a very large percent of the cells in the body have inactivated the same X chromosome. There are other reasons why females with, who are carriers of Duchenne, of the dystrophin gene, may have symptoms, and they're referred to as having balanced translocations or uniparental isodisomy. But we're not going to get into that today. I'm going to focus now on how I think care providers should be approaching the management of girls and women who have symptoms of dystrophinopathy. In many ways, the approach to care is very similar to the boys with Duchenne or Becker, especially for those girls who have more severe manifestations. I think one of the most important things to consider is to make sure you're receiving care in a multidisciplinary clinic if possible. This means care that's provided by a team of professionals including a physician who specializes in the care of boys with neuromuscular condition. Elizabeth, in her introductory comments, mentioned the care guidelines, and it's important, if available, that the care that's being provided is in alignment with those care guidelines. For most of you, the neuromuscular care will be provided by a neurologist. It's also important to be seen by a physiotherapist who will help monitor strength and function over time. A cardiologist will be part of the team and responsible for monitoring the heart function. And additional team members that could be very important include a social worker who may be able to help identify some of the resources that will be helpful in providing care. And psychologists or learning specialists that can help us understand any learning differences that may need to be addressed in a girl who is school-aged. Well, it's great to have all of these medical professionals in the same clinic space and seeing you at the same time. I recognize that this model doesn't exist everywhere. In fact, in my clinic, when a girl turns 18, they're transitioned to the university hospital or adult care, and that multidisciplinary care approach is not available to them. So they have to meet their needs by making separate appointments, something that many of you may be doing already. Because carrier testing is not something that's routinely done in young girls, it's really important that neuromuscular providers spend some time during their visits with the boys asking questions about their sisters or mothers of their patients. When trying to identify if a girl has symptoms, I can ask specific questions about weakness, difficulty with walking, climbing stairs, or getting off the ground. But there may be more subtle findings like exercise intolerance or easy fatigability that should be asked and may represent a symptomatic carrier. I want to ask questions about speech development, behavioral issues, and learning abilities of the sisters, as the same issues that we see in boys can also be seen in girls, including autistic-like features, as well as learning difficulties. If families respond that a sister is having any of these issues, whether it's weakness, fatigue, or the cognitive behavioral issues, I'll do genetic testing, but more importantly, I'll begin to manage those issues proactively and bring them into routine multidisciplinary care. Finally, when I have a mother of a newly diagnosed son, we do recommend carrier testing, but until that time we have those results, I'll ask questions about heart issues such as funny heart rhythms, chest pain, or shortness of breath. On a separate slide, I'm going to describe some of the monitoring recommendations for heart health. For all symptomatic females, we recommend routine health care, including routine immunizations. And now in 2021, that would include the COVID vaccine, and as I expect, a booster dose that will be available sometime this fall. I'm always asked whether a female with symptoms should be on corticosteroids as a standard of care, as it is with boys with Duchenne. To the best of my knowledge, there have not been any studies of the use of prednisone or deflazacort on girls. However, the consensus of our panel 2 years ago was to consider the use of steroids in those females who have moderate to severe weakness. In many ways, I would consider treating them very similarly to a boy with a classic presentation of Duchenne. It is really important to be able to monitor over time a female with dystrophinopathy using objective measures. I recommend using measures typical of what we do for boys, including time function testing, such as time to get up and go, time to walk or run 10 meters, time to climb 4 stairs, or even a 6-minute walk test, meaning the distance walked in 6 minutes. This latter test, the 6-minute walk test, may pick up some fatigability and endurance issues and a change over time. In boys, we use these results to predict progression of the disease and even the expected time to using a wheelchair full time. I want to emphasize, though, that we don't have the data to use these results to predict such things in girls or women. However, it is important to follow an individual patient over time as a current performance generally predicts future performance. Additional physiotherapy assessments could include the North Star Ambulatory Assessment, which is a commonly used test, and the performance of upper limb, or the PUL, for people who are not able to walk, but we want to measure upper extremity function. Some clinics will use formal equipment or machines to measure strength, but in some clinics like myself, I'll just measure it on my own. Once a physiotherapist completes their assessment, they'll work with a physician to develop a treatment plan, which may include a focus on stretching, a trial of strengthening, and also assessing the need for any equipment that may be helpful to keep people independent and safe. Similar to boys with Duchenne, a girl or woman can have some tightness in their ankles, and so a physiotherapist may provide a stretching program to help limit the progression of that restricted range. I did include strengthening as a possible recommendation, but it's important to point out that there's no real research that I'm aware of that has investigated whether this can be helpful or hurtful in a woman with a dystrophinopathy. I think it's always reasonable to try with light weights, monitor closely, and of course, discontinue if there's increasing weakness. As a rehabilitation physician, I also think about the use of equipment as a way to keep people active and out in the community. If you or a female with dystrophinopathy that you love has fatigability or difficulty with walking long distances, I am a big advocate of getting them either a scooter or a wheelchair, with the goal of getting them out of their house and again, participating in life activities. I believe this has a big impact on quality of life. I also want to keep people safe. So if someone is having a hard time standing in a shower or getting in and out of a bath, I want to provide them equipment such as a plastic chair so they can sit while bathing or showering. There's been a fair amount written about heart involvement in the female carriers of Duchenne. The rates of heart involvement range depending on what type of testing is done. In the past, an EKG or an echo were done, and about 15 to 30% of carriers have decreased ejection fractures or squeeze on echo. More recently, several researchers have looked at a more sensitive way to measure heart involvement, which is an MRI. Again, something that we use commonly in boys with Duchenne or Becker. With an injection of gadolinium or a contrast material, researchers are able to identify fibrosis or scarring in about 40% of women. Similar to what we see in the muscle weakness, heart involvement is seen more commonly in older women compared to girls. In addition, one study looked at whether mothers and sons had similar findings. 44% of the time, there was a match between a boy having findings or not having findings and their female relatives having that same result. Importantly, in boys with normal heart function, we would expect women, female relatives, to have normal heart functions. In other words, if a boy has normal heart function as a physician, I'm not going to worry as much, still monitor, but I'm not going to worry as much about the mother or sister's heart function. In the 2018 CDC Duchenne Care Guidelines, the recommendation was made to have the first cardiac evaluation in young adulthood. Practically, mothers of sons who are recently diagnosed are of that age, so we recommend that testing be completed once their carrier status is identified. In sisters who are identified as carriers, cardiac monitoring should be considered in the early 20s. If available, cardiac MRI with contrast should be obtained. But again, I recognize that this technology is not available for everyone. And so the routine EKG and echo are going to be just fine. It's a good substitution. The EKG is the sticker test. It measures the heart rhythm. And again, part of routine health, cardiac care for females with dystrophinopathy. If there is evidence of heart involvement, then the patient should be followed by a cardiologist who specializes in heart failure and prescribe the type of medications that we use for boys who have heart involvement. Women should be seen at least annually, if not every 6 months. Of interest, women may experience more symptoms of their heart failure, such as chest pain, exercise intolerance, or shortness of breath, because they are likely putting a little bit more strain on their heart because they're more physically active. Additionally, a woman who may not have symptoms of any heart failure during regular times may in fact start having symptoms during times of stress, such as pregnancy. Behavioral issues and learning issues are seen in boys with Duchenne, and they can also be seen in girls and women. Therefore, it's really important to screen for them and provide appropriate management strategies as needed. There are many different screening tools that can be used to assess for anxiety, depression, attentional issues, and even obsessive compulsive disorder. And I recommend including them formally or informally into clinic visits. If you've been identified or your daughter has been identified as having behavioral or mental health issues, then connecting you with an appropriate service or healthcare provider is needed. If your daughter is being seen in clinic or possibly not yet identified as a manifesting carrier, special attention should be paid to her school performance. You should think about whether they are keeping up academically with their peers, or whether the teachers are telling you your daughter's having difficulty paying attention. A child who doesn't like school, has behavioral issues in school, or doesn't want to go to school could be a sign that their school is really hard for them because of some learning difficulties. Assessing their carrier status, and as importantly, providing the support they need in school is going to help them be successful. I'd like to summarize the past 15 or 20 minutes by saying, first, it's important to recognize that girls and women who have a mutation in the dystrophin gene can have symptoms. And therefore, they need to be connected to a medical team that can help evaluate them, continue to monitor them over time, and treat their symptoms as they arise. Remember that symptoms can vary from being vague, such as exercise intolerance, or more severe weakness requiring a wheelchair. It can include cardiac involvement and learning and behavioral issues. When symptoms are present, the treatment can look similar to the treatment we provide boys with Dushen-Becker muscular dystrophy. We can use medications such as steroids, medications to improve heart function, and therapy and equipment to help maximize a patient's independence in their home, school, and in their community. One final comment I'd like to make is that I recognize that all women who provide care to boys and young men are Wonder Women. You get up in the morning and can spend much of your day providing care to your son, your grandson, or your brother who needs care that are varying amounts. So some with just a small amount and others needing total care. At the same time, you're caring for others in the home. You may be cooking and cleaning. And recently, during the COVID pandemic, you may also be acting as a teacher to your children. Of course, many have spouses or other caregivers in the home that are helping, but I do want to recognize the incredible care and compassion that you are providing each day. For those of you who are symptomatic carriers, this heavy load can be that much more challenging. I encourage each of you who are carriers to make sure you're getting the care you need to address your medical and emotional needs. For those who aren't carriers, make sure you're taking time to get the medical care and the mental health care as needed. You owe it to yourself, you owe it to your sons, and you owe it to your entire family. I'm going to end there and open it up to questions. Thank you very much.
Thank you so much, Professor Afekon. This was really an amazing talk, and I think a lot of people hoped for this to happen for a long time. I now hand over to Patricia Furlong, a board member of the World Duchenne Organization, who will moderate questions. Again, thank you so much. Amazing.